Doctors is joined by nationwide leading consultant neurosurgeon, Mr. Patrick Grover. And today, as part of Brain Tumour Awareness Month, we're discussing vestibular schwannoma, also known as acoustic neuroma. Good afternoon, Mr. Grover.
Hello.
Thank you so much for speaking to us today. It's a privilege to meet you.
It's a privilege to meet you as well.
So, could you tell us more about yourself and your work?
Yeah, so I think the main focus today is really to talk about skull-based tumours. And tumours of the skull base incorporates a lot of different pathologies, but particularly vestibular schwannomas and meningiomas, which can grow all around the brain, but they grow particularly around the base of the skull. My area of expertise is around treating and managing these tumours, either with surgical excision, but also with different forms of focused, minimally invasive radiotherapy, like gamma knife radiosurgery. I work primarily at the National Hospital for Neurology and Neurosurgery in central London, and also the Cleveland Clinic in central London. And in these centres, we have access to a very high range of expertise, both in the sort of open surgical excision of such tumours, but also in the general medical management and in oncological management with forms of radiotherapy.
Great, thank you. Okay, so let's get started with the questions. So straight away, what is vestibular schwannoma?
Well, a vestibular schwannoma is probably the most common tumour that I treat. It's a tumour of what we call the lateral skull base, and that's the part of the brain which connects to your ear. So these tumours grow specifically on the hearing and balance nerve, and that nerve travels from the cochlea, which is your hearing structure, and from there towards the brain into the brain stem so that you can hear. And vestibular schwannomas represent about 8% of all brain tumours, and they're quite stereotyped in their behaviour and also in the treatment options that we provide. So at a fundamental level, they are a benign tumour, so they don't tend to be cancerous, but nevertheless, because they grow in a very important confined space and push in on the brain, they can gradually cause significant harm and even threat to life if they get very big. Treatment of vestibular schwannomas is really focused around preventing them growing. And the main ways to do that are either an operation to remove as much tumour as possible and hopefully all the tumour, or we tend to do focused radiotherapy, and in my practice that's gamma knife radiosurgery, which is really the most common and most effective treatment for this worldwide. And the radiosurgery is a form of day case radiotherapy, which for the large majority, particularly of the smaller tumours, can prevent them growing any further. So if you have radiosurgery, you can avoid the need for open surgery. But then if you have a larger tumour causing significant symptoms from pressure on the brain, then those cases are more favoured for treatment via open excision.
Great, thank you. That's so detailed. And the next question, how rare are they? Statistics have shown a steady increase in incident rate over 40 years. So like I said, are they becoming more common?
It's difficult to say. So I think obviously in my practice they're extremely common. I will do a clinic seeing many of these patients every week, and I treat such tumours every week. In the general population, as I say, 8% of all intracranial tumours, and in terms of incidence, the incidence of new diagnosis a year is about 1 to 2 per 100,000 people. If you're looking at the epidemiology in terms of how many are diagnosed, there is a trend for more to be diagnosed per patient population, but then we also do a lot more scans than we used to. And there's a much higher prevalence of audiology testing. A lot of these tumours are picked up through audiology, which can be done at Boots, for example. And so you may find actually that the increase in incidence you're seeing is more that we're diagnosing them more frequently rather than an actual increase in the percentage of these tumours in the general population.
Absolutely. So it's to do with technology, it's to do with better healthcare. Absolutely. So when you hear the term brain tumor as a lay person, I guess, you immediately think it's a life-threatening condition. So is this the case with vestibular schwannomas, and how do they differ as well from something that could be maybe if they are life-threatening? Yeah, that's it.
Well, as I say, the vast majority of people with vestibular schwannomas are going to have no impact on their life expectancies. They should expect to live a full and normal life. Unfortunately, also the majority of people do lose their hearing in that ear. That's the main thing that is affected, but that tends to be well tolerated, and there are hearing aid options. It is fundamentally a benign tumour, and we have good treatments to stop it from growing and also to prevent progression with surgery. There is, unfortunately, a small percentage of these that can be extremely difficult to manage. And if you're unlucky, a group of these tumours, for whatever reason, can grow very rapidly or can grow more quickly despite treatments like surgery or radiotherapy. And sometimes those patients might need repeat operations or repeat treatments with radiosurgery or radiotherapy. And in rare circumstances, they can get to a stage where we can't really control the tumour. But in my experience, that is very rare. There's a percentage of these tumours that are associated with genetic conditions like neurofibromatosis. And that group of tumours tends to present in children and also behaves quite differently. So I think we tend to consider those separately. In terms of the terminology brain tumour, obviously that has connotations of malignant tumours, which grow within the brain themselves and are much more aggressive. That group of tumours is known as gliomas, and the most aggressive of those is the glioblastoma. And they are really a completely different disease. So those tumours require chemotherapy, radiotherapy, and they do have an impact on your life expectancy. A vestibular schwannoma, and in general terms, tumours of the skull base like meningiomas, are benign, and it's really just the fact that they grow slowly in difficult parts of the brain that causes the problems that for the majority is controllable.
Great, that's fantastic. So is treatment for vestibular schwannoma dependent on various factors? For example, the location of this tumour or the symptoms?
Well, yes, the treatment is really based more on the size of the tumour, and the rate of growth is taken into consideration, and the symptoms is taken into consideration in so much as the majority of patients will gradually lose hearing, but at presentation, some patients may have very good hearing and have their hearing preserved, and some patients may have lost their hearing already. So we take in multiple factors into consideration. And in broad terms, a small tumour or a small to medium tumour that is diagnosed initially, the first thing we will do is a follow-up scan at 6 months. Because what we need to do in the first instance is to understand the behaviour of the tumour. And actually, more than 50%, up towards 60 or 65% of these tumours that are diagnosed won't grow. And at that stage, you can then survey the tumour, and you don't need to take the risk of, or the small risk of, any treatments. If at 6 months there is growth, then there is a decision to be made as to whether or not you then intervene. And for the smaller tumours, particularly under 2 centimetres, generally focused radiation treatments like gamma knife radiosurgery are recommended. And then as you get into the realms of larger tumours, more than sort of 2.5, 3 centimetres, with pressure on the brainstem causing maybe brainstem symptoms or facial numbness or facial pain, then you're into the realms of surgical options to take as much tumour out as possible. And then with surgery, those operations are complex procedures. They have to be done with a large multidisciplinary team, and these are usually done in collaboration with neurosurgeons and also experienced ENT skull-based surgeons. So ear surgeons who often do parts of the operation involving access to the tumor through the ear bone, and neurosurgical procedures which are more kind of behind that area.
Okay, great. So what treatment plan do you favour in your practice?
So in my practice, I have a scheme, and essentially patients who present initially with smaller tumours under 2.5 centimetres, we will recommend a 6-month surveillance scan. If at that stage there is evidence of growth, then if it's feasible, I would recommend gamma knife radiosurgery. If, however, despite the fact that it's under 2.5 centimetres, but it's really causing pressure on the brainstem already or significant symptoms, surgery is also an option for those patients. And we take into account whether or not the patient has their hearing preserved. For larger tumours, more than 2.5 up to 3 centimetres, usually we would recommend surgery. Usually you don't actually need to wait for a 6-month scan because the tumour is already quite large and probably causing symptoms as a result. And when it comes to surgery, it's really a technical decision between myself and my ENT colleagues, Professor Saeed and Sharif Khalil at the Royal National Ear, Nose and Throat Hospital. And between us, we make a judgment as to what the best approach is for the tumour, for the patient's set of symptoms and for the configuration of the tumour. One thing that we've changed our practice in the last 10 or 20 years and really has made a huge difference to the patients is that with the ability for us to treat all these patients with radiosurgery really any time, that has meant that we do not need to be as aggressive as we were previously in having to get every little last tumour cell out in surgery. Now, the main issue with a vestibular schwannoma in reality is that it grows on the hearing and balance nerve, but the nerve to your face that moves your face on whichever side the tumour is also stretched over the tumour because it's in the same place.
Right.
And if you do an operation and you remove every last tumour cell and you irritate that nerve, sometimes it stops working and sometimes completely, and that can leave you with a facial droop or facial paralysis, which can be a very difficult problem to deal with. And that risk is variable depending on the centre and the experience of the centre and the surgical team, but that risk can be anywhere from 5% to 10 or 20% risk of that happening. And so now our practice is to do what we call facial nerve sparing surgery. So we will do the same operations but leave a rim of the tumour overlying the facial nerve so it's not irritated. And now the vast majority of patients will come out of surgery with normal facial function, 95% of cases. And the residual is then monitored. And if the residual, which is much smaller now, grows in the future, we can always treat that with gamma knife radiosurgery. And in the long term, that has very good results in terms of tumour control and also in reducing the rates of facial palsy.
Absolutely. So it really sounds like, you're considering the quality of life for the patient after the operation takes place and how they can be more comfortable in the future, regardless of not just the brain tumor, but for example, like you said, avoiding facial palsy, which is something that must be very difficult to handle. So that's really interesting. That's great. So what does living with a vestibular schwannoma look like for a patient? And how are they supported by medical professionals?
Well, as I say, for the large majority of people, you can live with a vestibular schwannoma with a normal quality of life. The symptom that is often first noticed is the gradual hearing loss in one ear, and usually that's well tolerated. There are hearing aid options, but unfortunately over time that hearing does tend to deteriorate, often completely. Secondly, patients can develop tinnitus or ringing in the ears. Again, that's variable, and usually over time that gradually becomes manageable as people acclimatize to that and as your brain gradually filters out that noise. And then finally, patients can also suffer with balance problems and with vertigo. And again, that tends to be fluctuant in nature. And in the long term, often with the right balance, physiotherapy is also managed quite well. There's a percentage of patients who have larger tumours. They may have more significant symptoms as a result of that, particularly in terms of balance. There's even very large tumours where you can require procedures such as shunt procedures if fluid accumulates in the brain. But even then, usually once you're on top of controlling any further tumour growth, your quality of life should be essentially as a normal person, but obviously with the hearing loss and slight balance issues. The support that's available, so we talked about balance physiotherapy. There's certainly support in terms of audiology and different hearing aid options through your ear, nose and throat surgeon. You can have tinnitus therapy if the ringing in the ears and tinnitus is very bad. And then you have your skull-based surgical team. In my practice, I have a specialist nurse who provides a liaison point for all our patients. And also we have access to psychologists so that if you have difficulties with certain aspects of the diagnosis, the psychologists can help you through that. The last issue really is facial palsy or facial weakness. If you are unlucky and have suffered that issue, then there's often we have facial physiotherapists who can work on getting the face moving again. You can have Botox injections for that. And also we have a facioplastic team who work with my ear, nose and throat colleagues, and there are nerve transfer procedures to help the facial movement in the long term, along with, again, psychological support.
That's great to know. It's really great to know. So we've come to the end of the interview, and I just wanted to say thank you so much. It's been fascinating, really interesting, and just learning the differences between what is malignant and what is benign, and also learning how people can go to boots about this is amazing, really interesting. Obviously, base level. So thank you so much. And if you're concerned about vestibular schwannoma or require expert neurological assistance, visit Mr. Grover's profile and the Queen Square profile at topdoctors.co.uk, and you can arrange a consultation. Thank you so much.
Thank you very much.